Hello students, welcome to today's session that is on one of the malpresentations, that is phase presentation. Here we are going to talk about phase presentation, the causes and the mechanism and cardinal movements. So definitions, as we have already learned what is malpresentation, what are malpositions and how do we diagnose them and the mechanism of labor and the cardinal movements. So to start with, only left occipito anterior and right occipito anterior are the normal presentation. You all know this. Malposition, if the occiput becomes posteriorly, then it is malposition. Coming to malpresentation, face, brow, breech, shoulder, cord, complex, anything other than vertex, everything else is malpresentation. So we have learnt about breech in the previous class. Now we will talk about face presentation. So before beginning with the face presentation, let us see the causes. As you've already learned in malposition, the same are the causes in malpresentation of face also. Like defect in the passage, defect in the passenger and defect in the power. So the passage, let us repeat and revise. Defect in passage is for contracted pelvis, android pelvis, pelvic tumors like fibroid uterus and uterine anomalies like septate or bicornuate uterus and placenta previa. These are the structures which prevent vertex or cephalic presentation. Coming to the defects in passenger, the defects in the passenger are preterm fetus, intrauterine fetal death, macrosomia, multiple pregnancy, congenital anomalies, polyhydramnios and cord around the neck. As we already told, if there is too many cord loops around the neck, then the head will not get flexed, head has to be extended and face becomes the presenting part. Coming to the defects in power, a pendulous abdomen, laxity of the abdominal muscles make the abdomen pendulous and it is more prone to have malpresentations in such patients. Example for a grand multipara. Dextrorotation of the uterus in anti-clockwise favors occipito-posterior position. Coming to face presentation per se. Face presentation, fetal head is hyperextended. You can see the head is hyperextended so that occiput touches the back. Here you can see the occiput is almost touching the back. The presenting part of the face between the orbital ridges and the chin from here to here will be your presenting part and mentum will be your denominator in face presentation. The incidence is quite uncommon, 1 in 500 to 1 in 2000. It is quite rare. Such a degree of hyperextension is also very rare. So, this is the presenting part and mentum is the denominator. Denominator is the mentum and coming to the position. Coming to face presentation, the position, you can see the head is fully extended and the denominator in face presentation is the mentum. Based on the mentum relationship with that of the quadrants of the pelvis. For example, so now you can see this is the mentum and this is left side. So the mentum is on left side and anteriorly. So it is left mento anterior. This is right mento anterior and this is right mento posterior. This side it is left mento posterior. Based on the mentum, wherever the mentum is there, right or left, based on that you will tell the position. The commonest position is left mento anterior. So how do we diagnose a case of face presentation? By history, not much, only on examination. Per abdomen, cephalic prominence on the same side as that of a back and a deep groove between them. You can see here the back and the cephalic prominence are on the same side and you can see a groove also here. So, head and back are felt at the same line with a groove. On per vaginal examination, during labor, palpation of soft parts such as nose, mouth and chin you can make out, whereas in vertex it is hard. So, it will be difficult to differentiate with breech. I will show you in the next photo how do we differentiate with breech. Coming to X-ray, we don't follow anymore. The other thing is ultrasound studies to confirm the presenting part if it is suspicious. In reality, only 3% of face are diagnosed antepartum. 35% are diagnosed in first stage and 27% during second stage and 35% only during delivery. See, how do we differentiate? Both face and breech has soft structures. So, how do we differentiate between face presentation and frank breech presentation? In the face, fetal mouth and the malar prominence are the most important points of palpation. In breech, it is anus and the ischial tuberosities. Here you can see in face presentation, the malar prominence, this is the malar prominence and the mouth. So, this forms a triangle, they are not in the same line. But whereas in breech, the anal opening and the ischial tuberosities will be in the same line. This is how you differentiate breech presentation from face presentation, because it will be very close space, it is difficult sometimes. The gum is felt hard through the mouth, whereas no hard object is felt through the anus. The examining finger may be sucked by the fetal mouth during vaginal examination and there is no sucking effect, but you can see a meconium if it is there. So, you already learned how to differentiate breech and face presentation. So, diagnosis on an X-ray. See, this was done long back, but this is not face exactly, it is a brow presentation. We don't do it anymore for diagnosing presentation. So, to begin with the mechanism of labor in face presentation. As we already told, left mento anterior is the commonest. So, let us begin. In a well-deflexed head, the submento pragmatic is the engaging diameter, that is 9.5 centimeters, where if it is partially extended, then it will become submento vertical, which is 11.5 centimeters. It occupies in the right oblique diameter. Okay, this is the right oblique, whereas the biparietal, the diameter of engagement biparietal is in the left oblique diameter. Engagement is delayed. So, the cardinal movements remain the same, engagement, descent. So, engagement in the face is delayed. Why is it delayed? Firstly, if it was a cephalic presentation, head is hard and it pressurizes on the cervix and dilatation is improved faster, which does not happen in face because face has softer tissues, not as hard as head. So, vertex presentation, the occiput has a good pressure on the cervix, hence dilatation is improved better, but in face it is prolonged, that is why engagement is delayed. Secondly, the vertex, because of the suture line, can undergo caput and moulding. So, this helps the head to squeeze in and easy to deliver, whereas the face cannot undergo caput and moulding. So, face again has difficulty in delivery. Though submento pragmatic is also 9.5 and the vertex biparietal is also 9.5 centimeters. Because of these drawbacks, the face is delivered late or prolonged in labor. Engagement is delayed and it occurs only when the face is at +2 station. When do we say it as engagement? When the biparietal diameter crosses the pelvic inlet. For the biparietal diameter to cross the pelvic inlet, almost face would have reached at +2 station. That is why engagement is always delayed in face presentation. Internal rotation. Firstly, engagement, descent, and now after that we will see internal rotation. It occurs little deeper in the pelvis than in vertex. Okay. So, the internal rotation occurs little deeper in the pelvis than in the vertex. So, once the descent is there, internal rotation theory remains the same. The part which touches the pelvic floor first rotates anteriorly. As we know, here the mentum is anterior and it touches the pelvic floor first. So, mentum rotates anteriorly by 1/8 of the circle. Here, then the chin hinges behind the pubic symphysis and face is at the pelvis, okay, at the outlet. Now, the face is delivered by flexion. You can see the face is delivered by flexion. Here, chin hinges behind the pubic symphysis and face is delivered by flexion. So, this is how it is. So, let us brief it again. Firstly, the engagement in left mento anterior, the engaging diameter is only submento pragmatic, which is also 9.5 centimeter, but the diameter of engagement remains same, the biparietal diameter. And since it is face presentation, biparietal crosses very late as face will be reaching +2 station. Then there is descent and further extension, and then the mentum touches the pelvic floor first and internal rotation happens. Engagement, descent and internal rotation. Here the mentum rotates anteriorly by 1/8 of the circle and the chin or the mentum hinges behind the pubic symphysis, and you can see face is at the perineum. Face is delivered by flexion and the rest of the body follows. So this is how the mechanism of labor in left mento-anterior. Let us see what happens if it is mento-posterior. Only if the face turns mento-anterior, vaginal delivery can occur. In persistent mento-posterior position, vaginal delivery is not possible because the short fetal neck cannot span the full length of the sacrum, which is 12 centimeters. This necessitates that fetal head and shoulders enter the pelvis together. What happens if it is left mento-posterior? I'll show you in the next photo. See, there is no more further extension or flexion that can happen. The fetus is stuck because face and the shoulders enter into the pelvis simultaneously. So the mechanism of labor is no more possible if it is mento-posterior. You can see this is anterior and this is posterior. If the mentum is posterior, it gets stuck. As you can see, the short neck cannot span the full length of the sacrum and the fetal head and shoulder enter the pelvis together, which is not possible. Once the thorax is thrust into the pelvis, the bregmatocosternal diameter, which is almost 18 centimeters, has to enter the pelvis, which is impossible and labor gets obstructed. Okay. So that is why in face presentation, if it is mento-posterior, there is no mechanism of labor unless it rotates mento-anterior. How do we manage it in labor? Almost 75% of them deliver vaginally and only 25% require cesarean delivery. Operative vaginal procedures such as forceps extraction may be done and vacuum should never be applied in face presentation. In labor induction, augmentation, outlet forceps delivery, as equally as in vertex we can use them. Okay, it is the same. The outcome, risks, complications, everything is the same. Okay. So induction, augmentation and outlet forceps, everything remains same except that vacuum should never be applied. So before concluding the mechanism of labor with face presentation, let us highlight a few points about post-dated pregnancy. So how do we diagnose a case of post-dated pregnancy? By history. You should confirm her last menstrual period date, whether she is sure of her date, and calculate her EDD. Okay, if wrong dates are there, that is the most common reason for indication of preterm or saying it as postterm. Wrong dates should first be ruled out, and then you should ask her if she has past history of post-dated pregnancy. And also you should check her investigations for scan and confirm her scan EDD with the LMP gestation EDD, whether it is corresponding or no, and if she has any associated risk factors. If so, then we should not allow her to have a post-dated pregnancy. Coming to examination, nothing much will be found on examination except that the liquor might have been reduced, because liquor is at maximum at 36 weeks period of gestation. Thereafter it starts reducing almost to half by 42 weeks period of gestation. So the liquor around the baby might be reduced and the baby might be big. Okay, more chances of having big baby. Hence delivery might be difficult. Intranatally it might be having a difficult delivery, like operative deliveries, maybe forceps or vacuum and cesarean delivery. So the delivery in such patients will be difficult because of big baby and hard formed head. So there is not much of caput and molding. So difficulty in delivery might be noted in such cases. So how do we manage a case of post-dated pregnancy? So before going to that, what is post-dated? That is, first is term pregnancy. It is early term and term. Early term, that is 37 to 38 plus 6 weeks period of gestation is early term. 39 to 40 plus 6 weeks period of gestation is term pregnancy. So next coming to late term, that is 41 to 42 weeks period of gestation. What is post-term? Post-term is more than 42 weeks period of gestation. Then we say it as post-term pregnancy. So now you have a patient with post-term pregnancy. How do you manage her? So management includes investigation. So what all you will investigate? The maternal condition and the fetal condition. So maternal basic investigations will be done. You will assess her pelvis. Okay, pelvis should be assessed to say it as CPD or no. If CPD is there, then she will go for elective cesarean delivery. Fetal condition, you should assess the fetus by biophysical profile. What does biophysical profile include? It includes the respiratory rate and fetal tone movements and AFI. These are the inclusions of a biophysical profile. Every score has 2 points, total of 8 by scan and 2 points extra by NST or a CTG. So you will monitor this full and give a score on 10. If the liquor is adequate and the baby is healthy, you can wait from late term to post term for induction of labor. What is modified biophysical profile? The modification is you have to check only for the AFI and NST. Okay, a single vertical pocket of more than 2 centimeters and less than 8 centimeters says normal liquor. A single deep vertical pocket of 2 to 8 centimeters, that gives your AFI, amniotic fluid index. Now you have assessed the maternal and the fetal condition. Now you will go about induction. You can wait up to 41 weeks for spontaneous onset of labor if there is no other high risk factors. Everything else came normal, then you can wait up to 41 weeks. If there are any high risk factors like GDM on MNT, hypertension on treatment, then you can terminate her by 40 weeks by induction of labor. Whether you will induce the patient or go for elective cesarean depends on the condition of the mother. Like you will assess the pelvis, and if there is any gross CPD or other contraindications for vaginal delivery, then only you should take for elective cesarean. If not, you should induce the patient based on the Bishop scoring. Based on the Bishop scoring, which we have already dealt in one of the classes. You will assess the cervix by Bishop score and then give induction of labor if the cervix is favorable or unfavorable. Based on that, you will decide what is the mode of induction. And the labor progress intranatally should be monitored by labor care guides strictly, as they have more tendency to have prolonged labor, difficulty in labor, as the baby is big, liquor is small. Hence, we should monitor with labor care guide very much carefully. So now coming to the complications of postdated pregnancy. So these patients have more chance of oligohydramnios, meconium stain liquor, cord compression and difficult second stage of labor due to big baby. Hence they can have traumatic deliveries like forceps or operative deliveries. They have more chance of traumatic PPH also. Coming to the fetal complication, they are likely to have fetal distress, IUGR and sudden intrauterine fetal death, especially intranatally due to severe grades of fetal distress by oligohydramnios or cord compression. And the newborn may have NICU admissions. Hence, the morbidity and mortality in the fetus is high with the post-term pregnancies. So, this brings to the end of this session on phase presentation and prolonged labor. I hope you understood it well and will be able to replicate in your exams. Thank you.